Hello and welcome. My name is Joseph Saramelli, and I oversee grand rounds for the Department of Psychiatry and Behavioral Sciences. And thanks for joining us today for grand rounds presentation. For this academic year, we're aiming to have a grand round series focusing on a theme of next steps in care include, which will be a series of presentations on innovations and updates in clinical care. And there's a group of us who work consistently on grand rounds, which includes two department staff members, Samar Abraha, working on coordination and communications, and Mike Walker, working on technology. This series is funded by the Ripley Fund and at times by institutes and centers in the department, such as the Garvey Institute for Brain Health Solutions. Note that today's presentation will be recorded and archived on our Grand Rounds website. And after the presentation, please complete the brief evaluation. I'll put the evaluation in the comment box so you can just click on it and complete it even towards the end of the presentation today. As always, you can write directly to me with any comments or suggestions if you'd like. And now I'll move on to talking about today's presentation. So today our Grand Rounds presenter is named Dr. Eric Rafla-Yuan. And Dr. Rafla-Yuan is an assistant volunteer clinical professor in the Department of Psychiatry at the University of California, San Diego, and is the 2021 American Psychiatric Association Gene Spurlock Congressional Fellow. And this is really notable. In fact, Dr. Rafla-Yuan is in Washington, D.C., and is working in this one-year fellowship. And this is intended for early career psychiatrists with significant interest in child and/or minority mental health advocacy to work in a congressional office. I had a chance to learn just a little bit about this, about Dr. Rafla-Yuan's work, and that's some of what we hear about today as well. So some biography. Dr. Rafla-Yuan completed psychiatry residency training at University of California, San Diego, including serving as chief resident in the community psychiatry program. And Dr. Rafla-Yuan's scholarly work and professional experiences include a range of topics within social determinants of health, policy, and health outcomes. In a recent article, blending these domains, authored by Dr. Rafla-Yuan and two colleagues, was published in the New England Journal of Medicine on the topic of crisis response, policing, and equitable psychiatric emergency services, which is the topic of today's presentation. So I'll stop there for now and turn it over to Dr. Rafla-Yuan.
Thanks for that wonderful introduction. It's great to be here with you virtually. Again, as he said, so my name is Eric Rafla-Yuan, and I'm coming to you from Washington, D.C., where I serve in the United States House of Representatives as the APA Gene Spurlock Congressional Fellow. And so today we'll be discussing the history and nature of psychiatric emergency services in the United States, up to the very present day and even into the future a little bit, actually. And so I'm also happy to report that Washington State has been a leader in this area. So we'll spend a moment on that as well. And hopefully by the end of the talk, you all have a good understanding of how effective psychiatric crisis services not only improve health outcomes and a large number of other associated measures, but also advance equity if comprehensively implemented. And so with that, let's get started. And so this is the part where normally I would ask questions to the crowd and you can yell answers at me. But since we're virtual, I guess the next best option is for folks to put them down in the chat if you're able to do that. So let me just pull that up real fast. Okay, so today, who would you call if a patient, friend, family member, or yourself was having a heart attack? 911, yes, look at that, instantly. So you call 911, and who would you expect to respond? And so maybe I'll get us started off. So maybe police if you call 911, but probably you get EMT, an ambulance, paramedic, perhaps fire department. And so when they get there, what would you expect that they do? What would they be able to provide? And again, you can put a couple of answers down. And so, at least for me, I would expect that they could provide an assessment, some sort of triage, some sort of services on site, and that importantly, they could get me to where I needed to go. However, who would you call today if a patient, friend, family member, etc., was having a psychiatric emergency? And so this is a little bit trickier. Probably you would still call, in most of the country, you would call 911. And who would you expect to respond? And so for these last years, what I'm really interested in seeing what folks' answers are. So who would you expect to respond to call 911 for a psychiatric emergency? And so I see a couple answers, looks like police or PERT if you're in San Diego, which is true in some cases if there's a PERT team available. What would you expect that they are able to do? And so this, feel free to put down what your experiences are, but it's all over the board. And so at some places they can just provide transportation. At some, if it's a PERT team, which stands for Psychiatric Emergency Response Team, they may be able to do some more assessment and evaluation, but still really no treatment or anything like that. And so before the 1970s and later than that in most places actually, police and sometimes coroners or funeral home staff responded to medical emergencies. So I know it's a little bit hard to believe, but what would happen is police would transport patients in their police cars or police vans, and funeral home staff would use hearses, like those kind of big, funny-looking car van things. And so basically, both of these only provided transportation. And the medical world really did not consider individuals in need as patients, quote unquote, until they arrived at the doors of the hospital. So until they got there, it was more or less someone else's problem. However, so that's not the standard today. So how did we get from that to the understanding and standards we have today? So we'll go through a little bit of more history. So here's a bit of a busy timeline on the evolution of emergency medical services in the US. And so I'll highlight a couple of important parts. In 1966, the National Academy of Sciences released a report just titled Accidental Death and Disability, the Neglected Disease of Modern Society. So that report focused on the growing number of people who were dying before reaching the hospital. And so a significant number of these deaths were actually related to automobile accidents, which in itself was a function of the growing number of highways that were built after the Highway Act in 1956. But also the stem of the report was the growing concerns of physicians and researchers. And so really in this report, they called on Congress to create a national emergency system that could respond to the folks who were dying before they ever got to the hospital. And around the same time, I believe in 1968, ACEP, the American College of Emergency Physicians, formed. And then in 1973, Congress did act and pass the Emergency Medical Services Systems, EMS Systems Act. So that both mandated and funded nationwide infrastructure, which included dispatch systems. So both the mandate and the funding are important here. And so the reason for that is that without both, you probably just have a patchwork of different systems, and some areas would likely have none at all. And so integrating a lot of these developments, and in 1973, the American Medical Association held a meeting in Chicago to debate the need for this new specialty. So influential in this point was Nancy Caroline, who's a critical care physician. Let's talk a little bit more about her later, who heavily advocated that physicians had a duty to care for patients in the street. And so AMA did approve the formation of the EM specialty, and so that's led to our modern emergency care, which we rely on every day today. And also in this timeline, you might see Freedom House mentioned a few times. And so what is Freedom House and why is the Freedom House model important? And so if you happen to read this article that Dr. Sarmelli mentioned, you may know the answer to that question, but to recap, this spring, my colleagues and I covered some of Freedom House's history and contributions and how we can apply these today to psychiatric emergency services. So here we have a great picture, I think, of Freedom House ambulance. The original is in the archives at the University of Pittsburgh. So there's Nancy Caroline on the left, you mentioned her earlier, and a medic on the right, and this is inside of a Freedom House natural ambulance unit. And so remember at the beginning of the talk when we went over how there were no ambulances, but it was mainly police who responded. So in Pittsburgh in the 1960s, police were deprioritizing or not responding at all to calls for medical emergencies in Black neighborhoods. And so that part of the story, unfortunately, isn't unique to Pittsburgh. But what is special here is that the Black community leaders, including James McCoy Jr., who is a local NAACP board member and also president of the nonprofit association or organization called Freedom House Enterprise. So community leaders partnered with physicians to develop their own solutions. So a bit of a background on Freedom House Enterprise. So that was a Black-run social service nonprofit, and their main goal was to help Black community members find employment. Also at the time, the University of Pittsburgh was the world-famous anesthesiologist, Dr. Peter Safar. And so I didn't know this until I started learning more about Freedom House, but he actually invented CPR. And so when approached by Freedom House, he decided it was an ideal opportunity to put his new resuscitation methods into practice. And so they started and rolled out for a few years, and a couple of years later, they were joined by Nancy Caroline, who came on as the medical director. And these experiences were really instrumental in her becoming a leader for advocating for physician response later. But what Freedom House did that was really remarkable was train previously unemployable Black community members as professional medics. And so very bluntly, so what unemployable meant, and what that means is that Freedom House would go ask unemployed Black people who were on the street if they wanted to work. And at this time, there was a notion that these folks were sort of unemployable, unreachable, and more or less a burden on society and were not able to support themselves or contribute. And so what Freedom House did was give them the opportunity to work, and if they said yes, they hired them and trained them. And train them they did. So these folks learned how to perform CPR, EKGs, intubation, administer medications, and all of this in the field. So this was something that had never really been done in a widespread manner in the civilian world. And so some of these techniques had already existed, but were only being done by physicians inside of a hospital, never in the field outside of a combat zone. And so integrating all of these skills for medics who were able to respond to emergencies in the street. So Freedom House was able to integrate all of that and had such good success with it that it actually became a premier model in the nation. They were asked to demonstrate programs all around the country. Even in Pittsburgh, police began to request that Freedom House units respond to medical emergencies in white neighborhoods because both police and the community realized how good they were. And so importantly, this led to a new standard of care, which was professional clinical teams who were trained and equipped for responding to clinical emergencies in the field. And so now, coming back to 2021, despite these wonderful histories and precedent in emergency medical services we just went over, police still respond to the large majority of psychiatric emergencies. And that's more or less what most of you were able to put in the chat from your experience as well. And so we still expect our psychiatric patients to figure out how to safely get to treatment, even if they're in the midst of an acute psychiatric crisis. And because the nature of psychiatric emergencies often remove our patients' ability to appropriately access care, we've abdicated that job and rely on the police to do it instead. But there's a tremendous price to pay when police get involved, and our patients pay that price. And so police response sort of broke down to three main categories here, but each one of its own is very important. Police response leads to incredibly poor outcomes, which aren't improved even with further training. And there have been lots of efforts for further training. Police are also quite expensive, cost between $200,000 and $300,000 per year to maintain a police officer on the Los Angeles Police Department. Part of the reason why these outcomes are bad and don't improve with training is simply that it's not what law enforcement signed up or are designed to do. So police are oriented to enforcing laws and order and respond to mental illness typically as a threat to be neutralized. And so probably one of the best outcomes you could typically hope for in an acute situation is that they safely provide transportation to the hospital. And so this does a number of things, but it also criminalizes our patients, both figuratively and literally. So having a criminal response team come to psychiatric emergencies really worsens stigma and the idea that mental illness is a criminal issue. And individuals who call 911 for psychiatric aid, it's not uncommon that they get charged with criminal or civil offenses, either related to the nature of the actual complaint or things that the police officers notice when they get to the scene. And then in terms of racism inherent in policing, so this third bucket here is its whole talk on its own. So I don't have time to go into more detailed history as I'd like, but hopefully you'll have some awareness of the historical and continuing racism that undergirds police in this country. But I do want to highlight a couple of important historical notes as they're relevant for crisis services. So policing patrols, which were later organized and incorporated in city governments as police departments, were originally developed to maintain racialized social order and protect property, which included Black bodies. But it's not just a historical footnote. For many years, police have been weaponized against Black and other minoritized communities. So at the top here is a headline, recent headline from the Los Angeles Times. There's also a table there on the left. And so this is from a recent study in the Proceedings of the National Academy of Sciences. So this study went through a lot of data and showed that being killed by police is among the top 10 causes of death for Black men and boys. And so up there with all the other things you'd guess, like heart attacks, automobile accidents, et cetera, being killed by police is actually there in the top 10. So it's sort of horrifying. Also, shifting over here to the right, so this is not from the LA Times article, but actually is the 2020 budget for the city of Seattle. And so it's not just the police themselves, but all the funding that the police get, which comes at the expense of funding for health and social services. And so on the right here, you can see that half of Seattle's budget actually goes to police departments. And the little orange slice up there is health and human services, which is just 1/5 of what policing gets. And so, oops, sorry. An important point here is that even well-intended policies continue racist practices if we don't account for the systemic racism that's ingrained in the infrastructure. So an example of this, both up here in the pie chart, as well as federally. So if we look at the Department of Justice gets many millions of dollars to dole out to prisons, jails, and police departments to provide mental health services. And so on its face, it seems like a good thing and does provide some benefit. And there clearly are folks who are incarcerated in those systems and need care. So, in some ways it makes sense, but that is funding and support that could have been used to develop services in the community. And so what we have are patterns where entire neighborhoods in these entire neighborhoods, the only substance treatment programs available are through parole programs. And prison systems are the largest providers of mental health services in the US. And so the last item I want to cover on racism and policing is the 911 number itself. So perhaps we think of it as ubiquitous and it's always been around, but the first 911 call, so there's a typo on the slide, was actually made in 1968. The system was starting to set in place in 1967. What many people also don't know is that a driving force for its development in the 1960s was government and law enforcement who wanted to be able to quickly mobilize police to respond to civil rights protests. And again, in many of these cases, protesters were Black or from other marginalized groups. And so the rhetoric around this in the second half of the 1960s was Richard Nixon's eventually successful law and order presidential campaign, which word for word is the same phrase that Trump and other Republican leaders used to respond to civil rights protests in 2020. And so taking all of this, caring for community health needs is not, and by its nature, never will be the primary goal of law enforcement. And our patients deserve better than that. And so an important concept in this discussion is intersectionality. So here we have two groups that are at elevated risk for police violence and criminalization. So on the left is patients with mental illness, and on the right are racial minorities and especially Black individuals. There are other racial and minority categories, including trans individuals, indigenous individuals, et cetera. But for the purpose of this discussion right now, we focus on Black individuals. And so outcomes are worse for both of these individuals on their own. But when patients belong to both, or an individual belongs to both groups, so they're a Black patient with a psychiatric condition, then their risk is exponentially higher when police are involved. Okay, we are going to switch gears a little bit here. So here's a clinical vignette I pulled from New World. Just kidding. This is probably, I don't know, the worst joke of the presentation. So the scene is mom is asking you for assistance because she's not sure what to do about her son. And so go through that together. As a child, her son had similar socialization and academic skills as peers. He got good grades as a freshman and played on the basketball team in high school. But by senior year, his parents noticed he wasn't interested in college and had greatly decreased interacting with friends and family. He began to have episodes where he would become very religious and knock on neighbors' doors. These episodes escalated, and currently he hasn't slept for days. He's telling family he is Jesus and is walking around the neighborhood with a gardening tool given to him by a neighbor, which he is using to bless and grow plants. Mom is very worried about him, but he refuses to go to the hospital because he doesn't think anything is wrong. She also informs you that he has no history of violence, no criminal record. And so what is your all's diagnostic impression? So you feel free to just like type these out in the chat. Not necessarily a wrong answer. So what do you think his diagnosis might be? And if you get to it, what do you think some treatment options, and what might you recommend to mom? What might you recommend to the family? Bipolar disorder, yep, definitely up there. So feel free to type stuff in the chat if you can. So bipolar disorder, maybe schizoaffective disorder. But, you know, the not sleeping part's kind of suspicious for that. Treatment, yeah, possibly substances. Treatment is perhaps he would benefit from some medications and seeing how he responds to that. What would you recommend to family? How could they get him to a place where they could get care? And so mom tried to take him to the hospital. He maybe went once and just quickly left and refuses to go back. And so perhaps could go to a PCP visit, but he's in the middle of a manic episode or something like that. You know, it's kind of a hard time to call up your PCP and schedule a visit in 2 weeks from now. And so what probably most of us do is if someone is having an acute psychiatric episode and their mom doesn't feel safe with them at home, is to call 911. And really there aren't that many other options. So mom follows your advice and calls 911 for assistance, getting him to the hospital for evaluation and treatment. But police shoot him within 60 seconds of their arrival to the scene, killing him. He didn't attack or threaten them, but the police department justified the shooting by saying he was holding a gardening tool, which perhaps could have been a potential weapon. His name was Miles Hall, and he was 23 when he was shot in front of his house by Walnut Creek police. But this doesn't just happen in Walnut Creek, California. This happens everywhere, and this happens much more frequently than we would like to think. And so to change this so that Miles' story stops repeating, we have to decouple psychiatric treatment from policing. And if we do so, we'll improve outcomes and equity, not just for Black individuals with mental illness like Miles, but broadly for all psychiatric patients and broadly for all minority individuals or communities that are seeking services. And so now, perhaps you're thinking to yourself, this all sounds good, but how are we ever going to change this? And so the answer to that question, fascinating, excitingly, is already here, and it's 988. And so again, mini quiz time, I'll bother you about the chat box. If I could see you all, I just ask you to raise your hands, but who here has heard of 988? Clearly, if you've talked to me in the last year, you'll know about it because I can't stop talking about it, but hopefully a couple other people also. So 988 was approved by Congress last year as a nationwide calling code for mental health emergencies. And so all phone carriers in the United States are required to support it by July 2022. At minimum, it replaces the National Suicide Prevention Hotline, which is a 1-800 number you've probably seen floating around. You probably don't remember the rest of the digits after that, and I have trouble as well. I think there's a 273 in there somewhere, but hard to memorize, but I bet you've already memorized 988. 988 will be accessible anywhere, anytime, but it's up to each state to implement its own 988 system and what services are behind the number. And so SAMHSA has released best practice guidelines to accompany the 988 announcement last year. I see a question in the chat on the status of 988. Glad you asked. Since I'm talking to you all in Washington, I have a Washington specific portion right at the end, so we'll get there. SAMHSA released best practice guidelines. So they recommend, and the evidence shows that mental health crises are best served by a comprehensive crisis spectrum of care. And so the SAMHSA's model for that is someone to call, someone to come, and somewhere to go. So let's walk through that for a minute. And I have this handy dandy visual, which I use whenever I'm explaining this, because I think it's so much easier. So up first, on the left there, you have a person in crisis. And to get help, they or a family member or friend, bystander even, can call. And so they call the crisis line, which soon will be 988. And so when they call, the crisis receiver is able to provide some services, like maybe brief supportive interventions or referral to services. So right now, if you call the suicide hotline, that's sort of the end of it. But what SAMHSA and folks around the country are trying to implement is this full spectrum. And so if we keep going through that, so brief supportive interventions, referral to services, and maybe the person calling just ran out of meds and can't reach their doctor for a refill. And so they'll all be taken care of on the phone. And so when Arizona was one of the first states to implement this on a state level. And so there's numbers up there from their state level data. But so they found a lot of stuff could actually be resolved on the phone when they actually had clinically trained staffers. But if it's more severe and the needs require in-person intervention, then a crisis center is able to dispatch a mobile crisis team. So that's the little van up there. And so these teams typically consist of a social worker or MFT, so mental health clinician, and a nurse or medic, and they're able to intervene in the moment wherever the patient is. And so they've been remarkably effective. And so one of the most prominent teams from Oregon called Cahoots found that of the 24,000 calls they responded to in 2019, only less than 1% of cases did they need to call police for backup. The next on their section, the little house. So if the crisis team isn't able to resolve it in the field, they're able to take the patient to a crisis facility. And so these go by different names. But the idea is that it's a safe and supportive environment. It's not an emergency room, not a hospital bed, not a jail, where a patient can stabilize. It's short-term, typically not more than 72 hours, could even be less than 24 hours. And also importantly, there to get linked to resources. And so that's the final very important step of this whole process. All of the steps in the spectrum are designed to connect this individual with longitudinal care services. So the flow of the current there is to the right. And so here's a picture of that Cahoots team I mentioned. Cahoots stands for Crisis Assistance Helping Out on the Streets. It started in Oregon, so again, some good Pacific Northwest representation. But you can see there in the van, they definitely got equipment. They're definitely equipped for the job. And this sort of reminds me of that Freedom House photograph. But even if you don't work on a crisis team, 988 will revolutionize mental health care as we know it. So for those of you in outpatient land, your patients will be able to access reliable 24/7 treatment-focused emergency psychiatric services. And you'll no longer have to rely on 911 operators and police to triage and manage your patients' acute psychiatric emergencies. For those of you working in the emergency room, perhaps there will no longer be hallways lined with gurneys waiting for psych hospital beds. And perhaps those patients can get care in an environment that's safe, quiet, and supportive, and it's been specifically designed for their needs. And for those of you in inpatient world, perhaps you'll be able to have beds for the sickest patients who really need them, rather than waiting in an emergency room for days. And I'm sure you've also all encountered numerous patients who only need a few hours or a couple of days to stabilize and then are quickly discharged. And perhaps those would be better taken care of in a crisis center that was designed for those quick turnarounds. So in review, 988, so just the number itself represents an incredible opportunity to decouple crisis response from policing to 911. But this will only be realized if the crisis spectrum is fully implemented. And that means that each step on the spectrum is available. So each little step that we went over in that graphic has to be available for this to be functioning. And if 988 is just a fancy new number for the currently existing suicide prevention lifeline, then we haven't gained that much. And so this is where the challenges remain. So making sure that comprehensive crisis services have both the funding and the mandates to be implemented everywhere. because we want 988 to be a real and robust option for instead of calling 911. And so we talked at the very beginning, and perhaps you've already forgotten because I've sort of rambled on for so long, but EMS got both a mandate and funding from Congress in 1973. And so without that, there would be this like patchwork. And so that's sort of what we're seeing right now with 988. And so we need people with experience working in these systems to get involved in advocating. So far, 988 has gotten a mandate for the number, so over that. Some federal funding, which is good. It's being administered to states through SAMHSA, but we need more of both. Luckily, even though the federal government has been slow to act, many states are stepping up to provide leadership. And so I'm excited to be able to tell you all and answer the question in the chat that Washington State, in fact, was the first in the nation to enact statewide 988 legislation, which I think it was either in May, I think it was May of this year. And so the Washington bill, which was HB 1477, utilizes a phone line fee to provide sustainable funding for those 988 centers. And so this is one of the best approaches to funding these, and it's actually similar to how 911 centers are funding. So this uses very similar infrastructure. It was your state representative, Tina Orwell, who led this groundbreaking bill. And some of you may know of her. She's a social worker who previously worked on mental health issues in local government and now represents Washington State's 33rd legislative district. And for those of you who don't know where that is, like me until this morning when I looked it up, that apparently is Kings County, especially South Kings County. Another thing to highlight and an important part of effective crisis services is that they're universally available. So no matter who you are or where you are. American Indians often face cultural, an example of this, American Indians often face cultural, sometimes even more so geographical challenges to accessing these types of services. And so it's amazing to see that there are special considerations and funding for them in Washington State's legislation. And even though it's brand new, your state's efforts seem to be off to a great start. And folks from University of Washington, such as Dr. Jennifer Stuber, who's been quoted in this article here. And I want to thank all of you and them for their support, supporting this important work in Washington and across the country. So looking ahead, lots to get done for 988 rollout, working with government representatives to get funding and legislation so that these full spectrum of crisis services are universally available. Some other next steps are advances in dispatch and safety, looking at how 988 interacts with 911 and police, and efforts to develop the 988 workforce. But at minimum, clinicians should know that 988 services are available, or should know what 988 services are available for the patients in their area starting this July. And so now some final thoughts. As psychiatrists, we must respond to our patients in the street. 988 offers a once-in-a-lifetime opportunity to decouple crisis response from policing. Simply shifting away from 911 and police advances equity for many groups, but continued funding and legislative action are needed to implement comprehensive crisis services so that just like for other medical emergencies, our patients will have someone to call, someone to come, and somewhere to go to get the care they need. And with that, I want to thank everyone and for your time and attention. Here are a couple of resources. I think hopefully you all have access to the slides. I want to end on this quote. The safest communities don't have the most cops, they have the most resources. And so with that, I want to thank you all again and look forward to a good discussion.
Thank you, Dr. Rafla-Yuan. Thank you for that presentation, walking through history, describing what's occurring now, and specifically locally as well. I'd like to invite participants to write questions in. There are a couple of pending questions. I wonder if you might take as others are thinking about what to write. But who's responding to these calls? I was wondering about that as well. Might staff work some days on 911 responses, some days 988 responses? Is it a different type of training? Is it different work in general?
Yeah, so that actually is an incredibly important question and incredibly relevant. It's something I think that almost all of the 50 states are looking at right now, and it's a little bit different in every state. I don't exactly know what's happening in Washington in terms of their on-the-ground mobile crisis teams, but I can give an overview of sort of the different models that are being implemented. And so One, that's sort of the one that we went over, which is the one that has the most evidence for being as effective as possible, is that clinical oriented team. And so there you have someone with mental health training or psychiatry training and someone with some sort of like medic nursing training. And so that's the most common one. That's the one that was first used. And so that one is sort of a model, but part of an issue is that we just don't have enough master's level clinicians to staff these. Like we don't even have enough master's level clinicians to work in the clinics that we already have. And so looking at the ability and importance of using peer support specialists, the possibility of doing new types of training. And so EMTs didn't actually exist until, as we know them, until the EMS system was developed. And so do we need something like a psych EMT where people are able to get training in those types of immediate skills? Because when you think about it, most of a master's level program is not really set on street eval, a crisis assistance. It's mostly for longitudinal outpatient-based care. That's what the majority of programs look at. And so, and the other thing that does is it's takes a long time to go through 6 years of training to be able to produce a clinician, whereas EMTs, depending on the state, can be done in just a few months or a year, depending on the state. And so, yeah, so that's one model. And then there are other ones which aren't as ideal. So one is called a co-response model. So that's where a police officer is paired with a clinician. So that's the PERT team that was mentioned before. A couple of issues with that. Funding and supervision, who's in charge there is still police. And the primary goal of that is still law enforcement. And then there's another model that also historically has been used but has not produced good outcomes, which is additional training for police. And there are different trainings that are out there that police departments use.
Thank you. Now, Dr. Raflio, you had mentioned about your interest in a discussion with the audience, and I think we have that opportunity. I've never done this before, but I would like to test it out. Dr. Mark Snowden says he has some additional information specific to Washington, I believe. And I'm going to try to allow him to talk. He's the chief of service. And are you okay with that?
Yeah, that sounds good.
All right, let's see how this goes. I'm going to try this, Dr. Snowden. You should be able to speak now, but you're muted.
Thanks, Joe. Can you hear me?
Yes.
Great presentation. I'm working with the Behavioral Health Institute here out of Harborview and the university with the legislators, Tina Orwell and Senator Dingra, on how they're going to implement this. And to the question about the call responders, there are 3 major call centers across Washington state that currently respond to crisis calls. They're trained at the level that's recommended by the National Suicide Prevention Hotline. And I think that's the plan for Washington going forward, that they keep that level of training and expertise. Right now, if you have a cell phone, in all likelihood, if you call 988, it will actually go to those call centers. So much of the work has already been done. The real challenge is, I think, as Dr. Raffel was saying, it's how do you standardize the mobile crisis outreach part, and how do you create enough crisis centers, and then how do you coordinate it with 911, because 911 is not going away. We're adding 988 to the system, but 911 will still be there. And so how you make it all work is, I think, going to be the bigger challenge.
Yeah, totally agree with that. And it's in some ways interesting, in some ways unfortunate that every state has to figure it out for its own. But that's more or less what we're seeing. And so, it's great to hear of all the developments that Washington State has had.
Now, maybe an ongoing question or ongoing discussion on this topic. A question came in about individuals now working in law enforcement. What will be their use of 988, or their understanding of it? Can you comment on that? Is there training about that resource specifically? That was
yeah, so broadly I can. Again, it's going to be specific for like every single department. So that's like part of this patchwork that I mentioned. But especially in sort of larger jurisdictions, so I imagine definitely in Seattle and places like this, MOUs or other types of agreements are being established to figure out what gets triaged to 988, what goes to 911, because folks are going to call 988, perhaps that should have called 911. A lot of folks are going to call 911 that probably would be better served by calling 988. Are the mobile crisis teams and everywhere available 24/7? So lots of like these interface questions to be answered. And so on the specific training, I imagine it would come through whatever that local department has decided on their sort of agreement. But the use of that co-responder model, which I mentioned, so that is the police officer paired with the clinician. And so there are a very small number of cases where you do need a police officer there, perhaps to help get that person to the hospital who doesn't want to go. And so for those ones, that's where perhaps that type of model could be used, and that's perhaps where we'll see the most collaboration.
You know, you mentioned about interface questions. I think if you talk to a lot of clinicians, people start thinking about treatment decisions or what happens clinically, which might prompt some of these issues, one of which is about welfare checks. Is this also kind of state determined or local area determined about who might respond to welfare checks, or is there some federal guidance?
Yeah, so broadly, and sorry about my cat running in the background, extra guess. It is within the purview of what SAMHSA recommends to be able to respond to those types of things. Because as we know, the folks who are high utilizers of the emergency room and inpatient psychiatric services often have really poor social determinants of health going on. And perhaps it's more of a social determinants of health, whether it's housing or something else, rather than the actual psychiatric issue. And so something that the CAHOOTS model in Oregon was very successful with was they were able to connect patients in need or clients to those things. Because maybe they're not even a mental health issue at all, but someone calls 911 because that person is acting weird, but that person is acting weird because they just broke up with a significant other. And so some other thing that doesn't necessarily need to go to the psychiatric hospital, but should get some support. And so those CAHOOTS teams, and we saw a little van, so they were set up not just for mental health stuff, but for connecting to social services, food stamps, substance treatment, housing, social work type stuff. So that should be within the purview of 988 in most places.
I'd like to encourage others to write in additional questions if there are some. One that comes to mind about another aspect of workforce development is how might a psychiatry trainee's role change? Learning about this, learning to be responsive maybe at the different areas on that figure that you showed, for example.
Yeah, so I think that's a great question and something that programs around the country are going to have to figure out. So at minimum should know what, and so I kind of said this before, what 988 is and how it operates in your area and how patients can access it. So that's sort of the minimum. And I think we'll probably at least see that. But interestingly, so the emergency medicine specialty, I had this on another version of the timeline, but I took it off. So that specialty was not developed because there were new advances in trauma and resuscitation or all these techniques. It was developed because there was this new system that needed guidance and direction and supervision. And so a couple of years after 911 and EMS system developed, that's when the emergency medicine physicians became a specialty, and their trainees are intimately involved with it. So as interns, they get sign out from paramedics and such in the emergency room, and as attendings, perhaps they're medical directors for EMS systems. And so looking at what psychiatrists' roles are in the system, I think this is going to be very multifaceted. But so there are definitely going to be clinical needs where there are psychiatrists who are supervising both perhaps the stabilization centers, the crisis teams, also in designing. So what are the needs of the folks who have illness? How can we triage this appropriately? What folks should get what types of services, as in like, how can we best serve them? So I think a lot of places where psychiatrists can get involved. And if psychiatrists don't, then others will, and whether that's police, social workers, psychologists, etc. There's a lot of activity in this space right now.
One question just came in I hadn't had a chance to read yet regarding 988. At this point, 988 going to crisis connections or other crisis lines following existing protocols. Is there a timeline for mobile outreach option outside of the community? outside of community programs with the police. I'm not sure that would that be more of a sort of local area determining that.
Yeah, I don't have that much to expand there. I guess what I will say is that there are federal efforts for funding and making sure that funding can go to the different types of agencies. And I guess there's state efforts too. So whether this is like a community-based program, they get a grant to show that their services are effective, or federal dollars going to FQHCs or such to set up these services. So there are a variety of ways to set these up. Part of what we're seeing and what we want to be careful of is that the existing infrastructure a lot of times is through the police. And so it's a very easy political fix to say, okay, well, I'm going to give some X dollars amount of money to already existing police departments to like take care of this better, to get more training and do a better job. But that's not really an effective approach.
Now, thinking about other areas where calls come from, and a very interesting comment from Dr. Collins about a group at UW has been working with the president's office to determine what might be alternatives to 911 on campus. This is a very large university, large campus. And a report was submitted to the university president, and it's interesting to see about 988, if it could be integrated into the planning. Have you heard about this on campus specifically, or any similarly large?
I haven't heard this specifically about school campuses, but I have heard this about different types of local jurisdictions. So for example, San Diego County has its own crisis line. It's running its own pilot programs for crisis response on its own county budget. And so they're now having to figure out how to align that with 988. And so there are approaches where you could just do your own thing and sort of see 988 as nothing really relevant and just be a new number for the lifeline. So I think that would be a really unfortunate approach, and likely, and is one that not as a minority of states are taking. So California, Washington, Oregon are not taking that approach. So with that, making sure that all of those efforts that have been going on locally are integrated with 988. But I don't specifically know about planning with campuses. I imagine though that since it's large enough to have its own police department, like some universities do, or own police force, that will be integrated in with the MOU and put whatever that area decides on for its response.
Okay, now 4 or 5 things came in. I think I'll just go sequentially for now. One says, psychiatry has a history of racism, and what should the field do to avoid perpetuating this within a new system, the 988 system?
Yeah, so another great question, something I spent a lot of time thinking about. A huge step is just to have a system that's clinically focused rather than law enforcement focused. So you shouldn't have to go through police or 911 to get mental health treatment. And this is especially so in communities that have more or less been really badly harmed by 911 and police. But really, for any psychiatric patient, we don't have an effective response. We rely on police to take care of them. And so what we see here is that moving towards a more equitable system is actually a more effective system for everybody. More specifically, as 988 rolls out, there are a lot of very intentional places to make decisions. So one is like, well, who gets 988 mobile crisis versus who gets police? Does dangerous neighborhoods get police and nicer, safer neighborhoods get mobile crisis teams? How do we determine what is too dangerous for a mobile crisis team? And so a lot of these are not really data driven, are more just what the person on the phone line thinks at the time, and then up to the officer's sort of discretion when they get to the scene. And so all of that, we know, is very susceptible to racism. And so there are a lot of places where we know the system is going to move in a racist direction, and that there will be racist bias on the ground, even if it's unconscious. And so we want to set the system up to account for that.
Now that leads into another question that came in, I think 2 kind of linked together. One is about if there's concern for outreach clinician safety. For example, if there's an observed weapon, is an example given. And I think maybe not related, but thinking about eventual transportation, perhaps to more intensive treatment settings until appropriate urgent care or treatment facilities are built. Emergency departments may or will be the default place should there be changes to emergency departments. So some about responding clinician safety and some about what about changes to existing emergency departments to be responsive.
Yeah, so two good points. So the couple, I'll say I have a couple thoughts on the first one. So one is that there are times when we would want police there. And so that is something that has to be taken into consideration, but also with that, knowing that it's the small minority of cases. And so depending on the studies, somewhere less than 5% or up to 7% of cases benefit from having a police officer there. And so those are cases where the person is brandishing a weapon or actually needs to be physically restrained in order to keep them safe, others safe, get them to the hospital, etc. For example, if they're put on involuntary hold, don't necessarily want the clinician to like have to physically bring the person to the hospital. And so that's where police steps in. But importantly, police is a backup call for that person. And so just like if an ambulance goes somewhere, they can call police if they feel like that would be helpful for that situation, but it's not police running the show. The other thing that I will say is that the standard of care that we have for keeping people safe right now really follows this assumption that anyone who needs mental health assistance is like a highly dangerous criminal, or at least poses some like really serious threat to them and everyone else around them. In the large majority of cases, we know this from many studies, it's not true. As we saw, a lot of crisis call things could be handled just on the phone line themselves. And so we also have to move away from the stigmatizing idea that people who need psychiatric help are by the definition dangerous. That's a large majority of them aren't. Talking about emergency rooms, and so yes, totally right that if those crisis centers aren't developed or built or available, geographically available, et cetera, that it will just be more access and less nowhere to take them. And so that will just build up demand for emergency rooms. And so that definitely is a concern and one of the reasons why things need to be built. And one, I think of the sort of 988 architect challenges, because it's like, how can you build that quickly? Like it's faster to develop a team than build those infrastructures and those actual facilities. And so that's definitely a challenge where we need both state and federal support and collaboration.
One comment from Dr. Mandy Owens: we're developing a training plan for law enforcement on how to interact with people who use drugs. Would this potentially be a resource? Oh, I see. An additional sort of way to present or develop curriculum.
For that question, do you mean like knowing that 988 is a resource, or?
Yes.
Okay, so yes, so I think that no one is opposed to having police have more education and awareness of psychiatric illness and substance use disorders. The issue that I tried to bring up is that when money, funding, and support goes to that instead of funding professionals to take care of the problem, or tend to the issue. But in terms of, I think everyone, so SAMHSA is like planning a large, they actually took on extra staff that are just like PR staff, just to help this roll out so that people are aware of 988. And so I think definitely having both people on the law enforcement side as well on the patient side being aware that it's there. Because there are definitely folks who will reach out for services if they don't have to go through police to get them.
All right, now we have a couple of minutes. If anyone has last questions, please write in. But I think this does open up a chance to ask a question about what your daily work is like. What is it like to work in the House of Representatives, to be in Washington, D.C. as a physician? What is that like?
Yeah, so it's a great honor to work in the Capitol buildings. And I will say that one of the things that really drove me to do some of this work that I'm doing, including the advocacy and then congressional part, is working so many nights on call in emergency rooms, seeing same people over and over being brought back into the emergency room by police for various psychiatric complaints, and having no good place to send them, and nothing good that I could really do for them except keep them in the emergency room overnight and perhaps offer them like food and someone to listen to. Because I couldn't change their housing. I couldn't change the fact that police bothered them. They were there if they were homeless, that police bothered them every night and every day about where they were. I couldn't get them services. They didn't really need a hospital bed. And even if they did, there weren't any. So like these types of issues that I saw couldn't be fixed or even addressed through like biomedicine. And so really through advocacy, I found, or I thought, and I am finding that I'm able to make an impact in the lives of patients.
Well, great. I haven't seen additional questions come in, just comments thanking you, commenting on the presentation. And I would like to encourage the participants today to complete the evaluation. I put the link in the chat a little bit later, but I just saw a comment saying the survey is not working. So I'll take a look at that. Well, Dr. Rafliwan, thank you for synthesizing this history, describing new strategies, proposing setting a new standard of care for psychiatric emergencies. Very motivating and informative. And thank you for joining us today for our Grand Round series.
Thank you for inviting me. And it's great to be with you all. And I hope that everyone learns something and can go out and serve all our patients and communities better.
Okay. Take care.
Bye. Bye, everybody.